Russ, thank you for inviting me to this talk, and Ian, what a wonderful introduction. I am just so impressed by how many people are here to talk about primary care. You need to come to New Haven and help us also. And it is really, one other thing I was shocked about in the first introduction is that Paul Revere was our first health commissioner. Did you know that, Lauren? That is an amazing fact. You all knew that here. Okay, so I'm not that revolutionary. I actually just am learning from all of you. Today I'm going to talk about our book, The American Healthcare Paradox, Why Spending More is Getting Us Less. And I want to begin with an acknowledgement and a warm welcome to my co-author, Lauren Taylor, who is right here. You might want to just wave. There she is. And this was really born completely of the two of us. And it's a great honor to talk about this, but I'm happy to have Lauren here to correct any of the mistakes I make. This is a picture of us in Scandinavia, which we'll come back to Scandinavia later in the talk. And this was actually an evening that we spent trying to put together what we were really understanding between the United States and Scandinavia. And why are we dressed that way? It's not just because Scandinavia is cold, although it was January and it was cold. But Lauren decided it was a good time to go to an ice bar, which I had never heard of, being the older side of our partnership. And nonetheless, we were sober for the entire thing, and it was quite an experience to be there. I also would like to acknowledge some new partners in this work, the Robert Wood Johnson Foundation and the Blue Cross Blue Shield of Massachusetts Foundation, who have provided funding to do some of the US-based work. So I'd like to first talk about the international data that we have, and then reveal some new data we're getting relative to the United States and where we're going with that. And I'm really looking forward to your comments and your thoughts about this. So everybody has seen this chart, I think. It is the percentage of GDP spent on healthcare across all countries in the OECD, so the high-income countries. And the United States, as we know, swamps the rest of the countries with spending about 18% of our GDP on healthcare. The average in the OECD is about 10 or 11%. So we've all seen this, but it's not just academics that have seen this. It actually has been seen and noted by our supreme power, the President of the United States, that knew back in 2009 and said in front of the joint session of Congress, so to the place you would think could do something about this or could get alive on this, said then there's the problem of rising costs. We spend 1.5 times more than any other country on healthcare, but we aren't any healthier for it. And yet, this actually has been known for maybe 30, 40 years. It's not just since 2009. People have debated this for a long time. Why do we spend so much and get so little? And I think one of the reasons that we have had trouble moving off the dime on this is there are some real benefits from this. So if you need a kidney transplant, this is the place to be. It will be higher quality, you will live longer. Kidney transplants in the United States, better. If you need a knee replacement, you'll get it faster, it'll be higher quality, you're more likely to get it if you're in the United States. MRIs. We have 26 MRIs per million people in the United States. How many are in this building, by the way? Oh, maybe not any. And so it's 26 per million here in the United States, and there are only 6 to 8 per million in most of Western Europe. So if you need an MRI, the United States is the place to be. And these are real important things, are populist values. But unfortunately, there are some very enduring challenges. So out of 34 OECD countries, these numbers vary a little bit by year, but approximately, we're about 25th in maternal mortality. The statistic that made me wake up was that our maternal mortality is 6 times that of Sweden. Just seems high. We're 28th in life expectancy. And we're 26th and 28th in low birth weight, near the bottom in low birth weight. And these are the broad public health measures. But actually, if you look at some of the other measures of chronic illness, we're very high in our obesity rates, diabetes, heart disease, chronic lung disease, disability rates, teenage pregnancy, HIV, it just goes on and on and on. The actual measures of health of our population are just not as strong as they are in our peer countries. The issue, which I think is critical, is not just about people who are poor. And very often this issue gets debated as, well, you know, those are people, substance abuse, poor, don't have the right home, don't have jobs, and that's it. But it's important to realize that if we look at the empirical data, this does not stand up. For the studies, and there needs to be more research on this, but for the studies that compare higher income, educated, insured people in the United States to their counterparts in England, in France, in Germany, we do worse. So it just feels that there's something different. There's something about the United States and the way we organize ourselves that is different when we come to how to get health. And our thesis in the book is that in the United States, we conflate health and health care. We just think they're kind of the same thing. And with Obamacare or the ACA, if you like it, Obamacare, if you don't like it, it's all about health care. What are we going to do in health care? And we think that will deliver health. But we have to step back. We have to step back and think, what really determines health? What has the literature told us for the last 50 years about what determines health? Well, generally speaking, about 20% of the premature deaths are thought to be related to genetics. Not a lot we're going to do about that immediately, and certainly not in our sort of health policy sphere. And about 20% is healthcare. But what's the other bucket? The other bucket is really the social, the environmental, the behavioral factors, where you live, how you eat, what your social relationships are like, what you work at, what kind of stress you're under. These are really thought to be the fundamental determinants of health, perhaps accounting for up to 60% of premature deaths. And in some diseases, it's much higher. Given this, the question really is, then maybe we ought to take a look back at some variable other than healthcare spending that could proxy for the attention a country spends on that middle red bucket. So we looked for data from the OECD that was on social services, things that would be such as employment programs, job training, income support, support of housing, some family assistance, nutritional support, and then a whole host of other social services that excluded the health benefits. And we tried to take a look at how much is each country spending on this litany of accounts rather than just their health care. And we called that the total investment in health, figuring that many of these other services are productive for health, just as healthcare. Theoretically, that should be the case. We thought, what if we add those two together, the healthcare plus the social service spending, what would it look like? So this is a chart that aligns the countries from, on the y-axis is the percent of GDP spent on both of these kinds of services. The blue bar is the healthcare, and the red bar is the social services. Now, first thing we see is all of a sudden the sort of stereotype that the United States spend more than any other country on healthcare, on health, doesn't appear to be true. We're sort of in the middle. I mean, we're high, but we're kind of in the middle. We're not really the highest anymore. And it also is apparent that we just have a completely different way of spending. Our ratio, if we're going to tax the population a certain amount, the way we allocate that tax money to either the health services or the social services is completely different. For every $1 in the United States we spend on healthcare, we spend about 90 cents on social services. And for every $1 that the OECD spends on healthcare, they spend about $2 more on social services. That is an enormous difference. It's just inverted almost. And in fact, that's exactly what we took a look at, is that ratio of social services to healthcare services. What does the ratio look like? And this is what the ratio looks like across the OECD. And if we start with this, and we see that what is this ratio really, all of a sudden the United States is actually at the very bottom. And of course, the question is, does this matter? Does it matter that when we have a certain amount of tax money, we mostly throw it towards medical care or health services rather than social services? Aha, inverted. Okay, that's what I just said. My printout is different. Okay, so let me step back for one moment before trying to answer the question of, does that matter? So people have called this phenomenon medicalization. And I think that medicalization is one of, particularly being a professor of public health, this is one of these words that can just be thrown around and cast the entire healthcare system into, oh, you know, they're just wasting our money and we're using. So we wanted to tease that apart a little more subtly and have a little bit more nuance for this. So we talk about in the book 2 perspectives on medicalization. Now let me start with the first perspective. The first perspective is one I think that public health people generally have in their brains when they conceptualize this problem. And it is the story, a true story, of a woman in her 40s that was playing tennis with her daughter very, very frequently because the daughter was on her way to really try to be more of a champion at tennis. And the woman basically wasn't in proper shape and went right out and played and played and played and had ultimately a shoulder injury of sorts, a bit of a labrum problem. I'm nervous about speaking about medicine in front of so many doctors. But you know, her shoulder, the rotator cuff, the whole thing hurt. So she didn't know much about healthcare, so had asked her friend, was well connected, ended up going to really what was known as the best orthopedic surgeon in a nearby academic medical center as the first stop. And he said, well, pushed it around a little bit and said, well, you know, the issue here is that you could go exercise and you could go get the right physical medicine and physical therapy, but the truth is that's 50-50 whether that'll make any difference at all. And so we'll set you up for PT, but then we're going to set up an MRI and, you know, we'll have you into surgery. There should be no problem with this. You'll be able to play in a year or whatever it was. And our interview of her was an interesting one because there was ambivalence in her mind about whether this was such a good idea or not such a good idea. You know, would PT actually work? Was there another way we could do this? And as she added up exactly how much was going to cost if she went all the way through surgery, it was going to go up to $30,000 or so. Versus asking some more people what else could be done. What ultimately happened is this woman spent about a year in physical medicine with the right trainers, slept differently, carried a different briefcase, et cetera, et cetera, et cetera, all the things that are not surgery, and ended up being just fine. Her reflection on this, which is just her experience of it, was, gee, I was kind of pushed to take too much medical care, and I had to defend to get something that was less expensive and actually did better. That's sort of the stereotypical, we've got a payment system that rewards more and more and more, and physicians will just push it down the throat in order to make more money. That's very stereotypical. And it seemed true, but not fully accurate. For that person, true, but it wasn't nuanced enough. So let's look at the other face of medicalization. Here in an interview with a pediatrician on the West Coast, looks beleaguered. I'm sorry those of you in primary care are going to primary care. This is primary care physician. And primary care physician told us a story. It's a complicated story of a family that he had taken care of for years. And he knew the young man he was taking care of, who was about 15 now, since birth. And he had been doing a good job with this family. The boy came down with chronic headaches, and he could not really focus in school. He was having a lot of trouble. So the parents brought him in, and in the beginning, it was the normal, check things, maybe try to do this, try to do that, but the headaches were not going away. And so the family, over the pace of about 6 to 8 months, became more and more intense about what could be wrong with this student's head and with his headaches. And he went for thousands of tests. The primary care physician, in revealing this, was horrified. You know, we need to stop, we need to stop. I've been trying to counsel, I've been telling them, you don't need a lumbar puncture, you don't need these other things. But the family was insistent, had the insurance, and was, in fact, I don't think he really thought he would be sued if he didn't, but it was in the back of his mind that this is a family that's saying, and what if it is something horrific? So after litanies of tests and specialists, I think the bill was $250,000, if I remember. Is that right? Yes. We have it in the book. At the end of the day, everybody said, he's stressed out. He needs to relax. And finally, the family took that, because pretty much every specialist had said, we can find nothing. So it's the other side of medicalization, which is on the left. I really think it's the supply side. In other words, maybe we have a system that forces people to take more medical care than they need or want. But we also have the demand side, which is the avarice public who understands this is sort of how I can feel healthier, go get some medicine. And you put these two together and you really have got an inflating situation. And I think that Abram Kaplan, really, we all know this phrase, but I think it's very opportune for the situation we are in healthcare. Give a small boy a hammer and he'll find that everything he encounters needs pounding. And that might be the kind of situation we are, and it's not in one camp or another. It's a confluence of these events. So it gives you a little sense of how we're thinking about this issue. Now the question is, does it matter? And so what we did was a statistical analysis published in BMJ Open to take a look over 10 years of data across the OECD countries and understand how statistically is this ratio of social to healthcare spending associated with outcomes. And in fact found in a multivariable analysis, countries with higher ratios of social to healthcare spending have statistically better outcomes. They have lower infant mortality, fewer low birth weight babies, less premature death, and longer life expectancy. So it matters. It matters. Now, we wanted to step back a bit and say, why does the United States spend this way? If this is sort of social determinants of health have been with us a long, long time, why does the United States spend this way? It just doesn't seem logical. It makes you wonder, are we investing in the thing that has the highest return on investment over the long term? And so we took a look at something that isn't always logical, it just is, and that's your history. And the history in the United States is very different from the history in Western Europe, obviously for many, many reasons. But one that's particularly germane to this is that healthcare and social services as sectors really grew up very independently from each other in the United States. And this did not happen in Western Europe the same way. In the United States, healthcare grew professionalized. It fit, over time, it fit into this marketable, a valued commodity that the middle class could take and buy and feel better with, that they would value. If they had money, they would value it and could actually value that in a marketplace, which is completely different from the history of social services. Social services were really conceived of as being not for the middle class, but for the poor. And we put that in quotations because it really is the poor, like somebody else, not the taxpayer, not me, them. And that this was really seen, our history puts social services in the responsibility of charity or the responsibility of some government or government duty. That's very different than the healthcare that's professionalized and marketable and valued and designed for a middle class group. And this is so different from what we've seen in other parts of the world. I wanted to just take a minute to tell two stories of frontline personnel perspectives in the healthcare and social services sectors that really, I think, describe the separation, which is historical, but is so with us today. And maybe the primary care center here will find the innovations that will knit this crevasse back together. But first I want to give a quote of an internist we interviewed and then describe the situation. I'm sitting here writing a prescription for this person who has limited ability to afford the medication or have insight on the situation, who can't go outside because the neighborhood is unsafe, and I am totally unable to do my job. This internist was someone taking care of someone with diabetes who was living in a pretty tough situation, had low education, low income, had all the risk factors. And the internist complained that I got 1,000 things I can do in medicine, but I just can't get that medicine to work the way it should when I have this patient wrapped in the social and economic challenges that she had. So it's sort of a place where the medical world just feels like if I can't connect to these other things, I can't do my job. And then we have the opposite side of this. Let me read it and then describe it. This is a social worker we interviewed who said, we have a client who was hospitalized 3 times in 72 hours because they didn't take the time to really look at what the problem was. They sent her home at midnight. The next morning before 7, an ambulance came to get her again. So here is a social worker dealing with all the social sides of this person's problems, but when sending them to get what she understood was a dehydrated patient rehydrated, the patient really wasn't treated in a way to do that at all. In fact, it's a pretty complicated story. The patient had AIDS and had a tremendous nosebleed, and actually the emergency department started to go into an entire approach to this that was very different from hydrating her, and ultimately said, you know what, this just needs to be outpatient, and sent her back without really checking on the hydration and other issues that were involved, unless at least this is as in the social worker's perspective. So what's interesting about both of these is the social worker couldn't really do her job either because the other side wasn't connected. So we saw it on both places, as is reflected in the data itself, in the cost data. Okay, so let's take a minute to leave the United States because it's so depressing at this point in the book. You know, we really just said, oh my goodness, can we find somewhere else to study something different? And actually, when we began the book, we really proposed to the publisher that we would end up studying Canada and England because we thought they had a national health system, and you know, everybody talks about the English NHS. Maybe that would be good to take a look at. But as we started to do our homework in these countries and read about what their outcomes really were and what they were suffering with now, to tell you the truth, we were not that impressed. We felt a little that they've got the same problems of separation in different ways that we suffer with in the United States. So we decided to look back over the 10 years and find out which parts of the OECD have sustained over 10 years the best outcomes. And so that brought us to Scandinavia and the ice bar at the beginning. And we spent time in 3 social democracies, Denmark, Sweden, and Norway. Now, you may be thinking that, and I imagine you are thinking because I know I thought this, that, you know, they are just so different. Look, the Scandinavians, they're all the same race, ethnicity, they're all the same height and weight, they're all, you know, they love the government, they're just different, they're small, you know, it's a small part of the world, you know, several million, but it's not nearly like the United States. But we did want to nonetheless say, well, is there a way we could still learn from them? You know, people talk about that, learning organizations, you're supposed to find out what others are doing and learn. And so we decided to spend a good amount of time there. Now, we spent, in addition to many of the qualitative interviews we did in the countries, we also looked at some quantitative data on values. And this uses the World Values Survey, which is a terrific publicly accessible database of 1,000 randomly selected, interviewed people in their own language about a whole set of values. And we really wanted to understand how different are we from a value point of view from the Scandinavians. And so I want to start with some pieces that we found to be surprising, which were 3 areas in which we're really similar. And in many ways, if we can sort of relate to some piece of it, maybe it's that much easier to understand how we're different. So I want to start with the similarities. The first is the value of personal freedom. So there's an item on the value survey that scale 1 to 10, how free do you feel to be able to accomplish, you know, your self-efficacy, to accomplish the goals you have for your life? And the United States is very high on this. People randomly selected report feeling very free, but so are the Scandinavians. So they may not be as free as we are, but they certainly feel as free as we feel. So in the area of personal freedom, very similar. Similarly, views about competition, which surprised us because we think of, oh, the government, does everything there, et cetera, and people talk about it as a socialist area. Some people talk about that. Probably not at Harvard, but some do in other parts of the country. And we thought, oh, they won't really support competition the way we do, but actually, we are indistinguishable in our support for competitive markets and competition. And then last, technology is a source of progress, that we really thought we would feel like we love high-tech things. But take a look at Denmark, Sweden, and Norway. They have very high spending on medical technology, and they do a lot of other kinds of technology. We're really not that different, and our values did not shape as different. Nonetheless, there were places where we were tremendously different, and these would be they. So the most important, I think, was the scope of the social contract. This survey asks people to rate what are the critical elements of a well-functioning democratic government. What does it do for its people? And in Scandinavia, the top thing that they rate is that it mitigates income inequality. That's what a good democratic government does. The second thing was that it promotes education and literacy and high education among its populace. And the third item on the list was it promotes health and well-being of the population. So that was 1, 2, 3. And we compared that to the United States. And 1, 2, 3 in the United States, number one was a democratic government doing its job for its people protects people from international threats. Number one. Number two was it keeps your neighborhood safe from criminals. Number two. And number three was that it promotes economic growth. So these are just different people, different places. They're like orthogonal to each other. And it makes some sense when you figure what Americans are. Every American is related to somebody. It could be 20 generations back, it could be 1 generation back, who escaped from some oppressive, typically government, had something in our myths about our world and who we are that is got a different relationship with government than many of the Scandinavians. And of course, we could go on and on of why that is and what World War II did, et cetera, but suffice it to say, this was truly different. We also had enormous difference in the views of income inequality and social mobility, with the Scandinavians feeling much more that this hurts society and Americans feeling much more, it's not all bad. Having a little inequality makes people work harder. And the third was degrees of trust. Scandinavians, tremendously trusting group, which you would expect given the homogeneity, particularly in height and weight. It's very, it makes sense that they trust their neighbors, their cities, their states, and other countries, more so, significantly more than the United States trusts each other. The interesting thing is there's tremendous hypocrisy in both societies that we talk about a fair amount in the book. In Scandinavia, actually, the hypocrisy is that for the general public, they give you access to the entire social welfare state. You are going to have health, you're going to have a job, you're going to have housing. You don't really see very many people who are homeless. How many people here are Scandinavian? Okay, so you can correct me if I'm wrong, but you don't see too many people who are homeless, and when you see them, they're not emaciated. So that access is something that Scandinavia really prides itself on. But the hypocrisy is, for people who are immigrating to Scandinavia, who maybe don't want to learn Danish, who maybe are not that excited about the baby clothing that arrives in the Norwegian this year colors for your baby to wear, who maybe don't really fall in, they may not get the job interviews. They may not get quite as much. And we know what happened in Norway. I mean, they have a tremendous challenge, and they talked a lot about this, of how do we extend what is our national value of inclusion and social welfare to people who will not speak the same language we do, to people who don't look like us. How do we do that and do it in a comfortable way? How do we manage difference? And they're struggling with that. In the United States, we have a similar hypocrisy in that our generic value is freedom and individualism. You ought to be able to be free and get what you want and work as an individual if you need to. But we're the first ones to constrain what you can buy with a food stamp. So it's hard for us to extend that national value to people who are marginalized, who might be on income support. We suddenly think, oh, maybe we ought to, they shouldn't have freedom to buy Coca-Cola with a food stamp, should they? So it's an interesting thing where having the generic, the thing we all really define us as a country, how do we extend that actually to people who are on the fringes? I think both areas deal with this and have trouble with it. One of the items that really came up very strongly was the conception of health in Scandinavia. This is just to contrast it with the United States. So here's a sign from the Winthrop University Hospital, which I believe is nearby, that says, "Your health is everything." And when you read that, you think, wow, that's really good. They didn't say your health care is everything. They didn't say your surgery is everything or your MRI. They said your health. So at first, we sort of lulled into, yeah, I buy that. That really makes sense. Thank goodness we're getting a culture of health in the United States. But in Denmark, the way this is really kind of like the head of the FDA type person in Denmark, says, people should know that health is not the goal of life, but health is definitely a means that you can use to choose exactly the life you want. Because if you don't have health, then your possibilities cannot flow and grow. It's interesting. Oh yeah, that makes sense. I want health because I want something else. And that allows this country, I believe, this popular opinion allows the countries to think about health differently and to balance it and medicine with other things that might achieve a high quality or well-being overall. A thing we may struggle with, and I think we really have to talk a fair amount, and it's the demand side. If this is how people are thinking about health, and we're thinking of it the other way, the demand side of this medicalization is a very tough thing to grab hold of. It gives rise, these values, this conception of health really gives rise to a strategy they use to allocate funding. And what they generally use is at a county level over 200,000, 300,000, 400,000, 500,000 people, they have joint planning and joint budgeting. So here's a quote from one of the senior policymakers in Denmark describing this process. It's a closed system where 80% of the decisions, even those that are decentralized, are made within the public integrated system. So if one department goes beyond its budget, somebody else will have to be below it. We saw and heard the direct negotiation of, do we cover a little bit more in the medical care here, or, oh, wait, do we need more in the area of education? That trading, negotiation back and forth, and creating an environment in which you can have that conversation was very prevalent in Scandinavia, and is largely absent here in the United States. I mean, the federal government is set up so that you could never pass a bill that had something to do with healthcare, education, and housing all in one, but you just couldn't do it. And it goes through different, our government is set up not to get something done at the federal level. So to have this kind of integration at a local level, you could really imagine it in the United States, and I think that's where the action will be. But we don't really have county government the way Scandinavia does. But this concept of integration, even at the policy level, was something they really understood and really used. And I think we could learn from it. So now I'd like to turn back to the United States for a moment to talk about what about inside the United States. And these are really new data, so I'm very happy to have people ask questions about it, and you'll only sharpen our work with it. So let's begin. A lot of people asked us after publishing the book and even the article, oh, what about the United States? Can't you do the same thing inside the United States? We've got 50 different experiments going on. Can't you get the data? Which, by the way, is not easy to get. So what about inside the United States? Our health services spending overall, 18.2%. Social services, 11%. Which is pretty much what we had expected from the previous decade of looking at it. But what's interesting here are the right column, the range, There's a lot of diversity, and this is as a percent of GDP. There's a lot of diversity in the country over how different states choose to spend on the social services or on the health services. So I want to give a map of the ratio, which is what we've used before to be predictive of outcomes. I wanted to give a map of the United States showing how the ratio of social to healthcare spending varies across the country. And we've looked at this in lots of different ways. Right here, I'm going to show you a map that has every state quintiled out. So the red states are going to be those that are in the lowest quintile of social to healthcare spending. And the green states are going to be the states with the highest social to healthcare spending. So this is what it looks like. The ratio runs from about 0.4 to 0.8. There's a real pattern in how this is done. Now, the question we have is really, is it related to health outcomes? And so here's the ratio of social to healthcare spending, again. And now the second data I'm going to show you are the states aligned by one health metric, which is obesity rates. And this would be, again, in the quintiles where the red will be the heaviest parts of the country, and the green will be the lightest parts of the country. So they're very similar. They're not fully similar. And the ratio is a tricky thing because you can get red by spending a lot in healthcare, or you can get red by spending a little in social services. You know, it's a ratio. Now, and that is conceptually because you have a certain amount of tax money, and how are you going to make your decisions? Now, let's see if this holds for other things. So this is the same map I showed you before, but this outcome will be neonatal mortality. Now, for us, I think that it is going to always be very hard to draw a causal stream to things. We actually are looking at these models with a lag, which will allow us to say, is the spending 2-3 years ago associated with health outcomes in the subsequent years? And actually, the lagged models look almost like the non-lagged models. The truth is, states are different. It's hard to say what comes first and what causes what, and what do we do about the basic income inequality that is immediately reflected in the social service spending and vice versa. But the patterns, you know, like a good epidemiologist, the patterns make us say, what's going on here? So happy to talk about that more when we get there. So I'm going to just go, because we don't know actually yet too much more about the specific buckets within social services and which of those are most effective, et cetera. There's still a lot more work to do there, but that's what we're hoping to accomplish in the next few months. So I'd like to spend a little bit of time talking about, is there any good news here? Vis-a-vis, are we ever going to kind of get a grip in the United States on the social side of health and the medical side of health? And of course, I think that many of you, some of you may have read about, I'll give 3 small sort of teasers of programs that do exist. And we know also here in Massachusetts, the Cambridge Health Alliance and much of the MLP. I mean, there's innovations all over happening at local levels. But just for a couple of ideas, this is a program called C-Train. It is in Portland, Oregon. Does anyone know what the ethnicity of people in Portland, Oregon tends to be? Scandinavian. There's a lot of Scandinavians in Portland. So anyhow, I don't know if Honora Englander, the woman in the white shirt who began this program, is Scandinavian or not, but it is nonetheless sort of an interesting thing. This is Oregon Health and Science University. It's a very tertiary care, quaternary care center, 570 beds, very much like the places we have around here. And it started a new program called C-Train. And what C-Train does, the nut of what makes this unique, is it is actually a transfer of resources to some degree from that tertiary hospital to this central city concern community center. The community center is not a community healthcare center, it's a community center. So it has cooking and exercise places and lawyers and the ability to get counseling for housing, to get people onto different S-chip, et cetera. What the hospital did was say it would really be worth it to us to identify people who would be readmitted and readmitted and readmitted and not really cared for very well. We could identify them as they're being discharged and hook them into the Central City Concern and get them kind of like a hinge, get them somebody who was a primary care physician, get them a hinge into the social services. Not that the primary care physician would end up doing the housing work, but rather just be the connector to this. And so they funded primary care physicians to work in Central City Concern, and they also funded, I think it's 2 months of medication supplies. You know, they really moved people into the post-hospital setting. Now, they did a randomized trial of this, which is a very unusual. We don't see a lot of randomized trials of these kinds of large-scale programs. And it found that C-trained patients have lower mortality, better quality of care, and the hospital is funding expansion. So they did not do a cost-effectiveness analysis, but revealed preferences here. The hospital CEO said, let's fund more of this. My bet is someone thinks this is paying back, that this is actually helpful to them. Now, there is an underbelly to this, because the question will always be, have they gotten their primary care people out to where they need to be, so now they can fill those beds with higher paying, really medical technology patients. So I'm not sure at the end of the day this will save money to society, but it has, it seems to, for this population, really been very helpful. And most important, both the CEO and the physicians are happy. How often does that happen? So here is a quote. It's really a coordinated intervention, and that is satisfying. I really got to be a physician. A lot of times here, we're used to playing social worker, play psychiatrist, when we're not necessarily trained to do that. We do medical care, you know, and so it was very refreshing. And that, if anything, I think is hopefully a message from this book is actually we have different instruments to create health, and people are trained in different ways. The question is how to coordinate it so everybody can be working at the best of what they went to work to be and really have the capacity to do. The second I'd show you is in LA, the 10th Dessel Project. This is a project that is a collaboration with Medicaid policymakers, and it works with hospitals to identify the top 10% of homeless people with the highest hospital costs and to find permanent housing with strong medical and psychosocial support. And has been going for about 8 months, and they report that they have reduced healthcare costs by about 72%, and you can see the absolute value drop. Again, a return on investment is not calculated here, but the concept is expansion here. Medicaid program's very happy, and the sense is the housing hasn't cost nearly as much as the savings in the healthcare area. And then last, WIN for Asthma, again, a great program, an academic medical center in New York, started this huge academic medical center, collaborated with a community center that had children that it was caring for with asthma rates 3 times the national average. And they started the bilingual community health workers, we've seen work all over the world, to provide comprehensive education, home-based support, and referrals when needed for housing, for immigration, getting into a mental health service worker, et cetera. This program has had just tremendous, and this is much older, this is a few years older, and consistently believes that they have achieved a 50% decline in emergency visits and hospitalizations, saving money, but even better, reduced school absenteeism. So 3 places where, and often it is the medical center that starts to really move this, that starts to think, how can we make things different here? But 3 examples where that separation has been sort of renegotiated at a local level. Of course, in the United States, the question is, can we ever do anything like this more than once? Can we have a great innovative program and replicate it, get it knit into policy and knit into our culture so that this is how our system works. And that we have a lot of trouble with in the United States. And our diversity, while fabulous for innovation, hurts us in terms of replication and sustaining. So I think we still have a ways to go there. I'll end in the dangerous territory of the ACA, just so we could get the conversation going here, and say, so what? What about the ACA? It's been a transformational change in the way the United States is really thinking about healthcare. And is this going to make a difference? If our problem is separation of the different instruments to keep somebody healthy, the social and the medical, will the ACA bind it back together or create the avenues so that we can have better conversation? And my first view on this is maybe. It is a platform. The great thing about a social commitment to ensure everybody, even as it has not been, hasn't been accomplished yet, the nice thing about that commitment is suddenly we are more of a collective. Suddenly Massachusetts cares about Alabama and Alabama cares more about Massachusetts, because actually at the end of the day we're all paying for each other. Now that's always been true, really, but now it's explicit in making a commitment to actually ensure everybody. So that's a really positive piece of it. I think a second positive piece is this potential to create something like accountable care organizations. I mean, it's got good words to it: accountable, care, and organization. But of course, there are problems with it, in the sense that there's several problems with it, and I'm sure in the audience we'll get a lot more discussion on this. One of the major problems of it is this notion that there will be measures that we will measure ourselves in accountable care organizations, and that these were meant to be measures that were cost of care, okay, patient satisfaction, excellent, and actually health. But if you look at CMS's measures, there's really not any about health. It's about health care. And things are happening. There are definitely efforts to try to think about, ooh, could we measure something that's more about health, obesity rates, mental health, et cetera, more about health. But as soon as you start to measure something more about health, then the partners start to say, oh, I don't want to be accountable for that. How could I, hospital, ever be accountable for the obesity rate among the assigned people? Please don't make me accountable. So this accountable care organization, the question is, accountable for what? So I don't think we've quite had that debate in a healthy way. We're still on the sort of quality of care accountability in the medical field. So I fear about that. The second part of the ACA that is disappointing, I think, it has very little on the demand side. It has very little in terms of trying, it really envisions the problem as a supply side problem. That we have to pay people differently, we have to organize them differently, we have to incentivize people differently, as opposed to, you know, here's the customer, they've got a lot to say about this. Now, corporations will figure out how to get the customer engaged, but who will do the work of actually educating our populace to understand health is determined by a lot more than medicine, and it's one thing on the way to well-being. Those are tough messages in our society, and I just don't know how our providers are going to actually achieve what the country thinks it's going to achieve without dealing with that demand side, and the ACA does very little of that. The last part of the ACA that I think is somewhat depressing is it really is about only healthcare, not health. So there's nothing in it. If we were really serious about health, we would actually give the same measures to housing agencies and the Board of Education, and we'd say, and the job training center, and the hospital, and the primary care physician. And say, you're gonna work on these measures together, and you all have the same measures. Because today, if you run a housing agency, you know, you get dinged if there are too many homeless on the streets. Well, how do you get people out of the street so you don't get dinged anymore? Send them to the hospital. So that's not helpful to the healthcare system. And until we're actually working across these sectors towards the same measure, how are we going to get collaboration? It's not going to be possible. We have actually been here twice before in the United States. Some of you I know are old enough, as I am, to remember this, the neighborhood health centers. You know, this was an incredible innovation in 1968. Block grants given to a set of providers of all kinds to take care of defined populations of patients, communities really. They had all the pieces to it that you would imagine. Some created farms. There were a diverse set of providers in these. The boards had community members on them. They thought about the whole patient, the whole health. And please read chapter 6 of the book. There is quite a sordid history about how these got taken down and medicalized over time. Mostly related both to the AMA and its fears that this new model was encroaching on that middle-class medical model, but also a general change in politics. You know, this was really created out of the Kennedy-Johnson vision that we can't build a fully employed population unless they're healthy. And it kind of was their child, if you will, and was never knit into the real policy-making Department of Health and Human Services. It was put out here almost like an institute in a university, not like inside the real thing. And so in the Nixon era and, you know, with the crash of the economy in 73, 74, these were really defunded. They were really refunded to not be block granted, but the only way you could get reimbursed would be to bill Medicare or Medicaid. And that, of course, changed it because all you can do there is medicine. So that was tough. It was kind of a supply side shift there. And we also were here again with Nixon in 73. You know, the early days of the HMO Act were very health oriented. Let's, you know, try to keep people healthy. But what happened with that? We know over 20 years there was a lot of warping of what the original vision was, and ultimately constraining of costs to such a degree, constraining of medical services to such a degree that the population would not stand for it. And legislation after legislation, Connecticut, California, started to pass to say, you cannot restrain us as much as you are restraining us in HMOs and in managed care. So sort of our population ultimately, I think, really shifted the way the HMO movement ultimately was not able to achieve its aims. So I'm going to end with a final talk about values again, because I think at the end of the day, that's where we are. I mean, we have what we value. And will this shift? I don't know. The values of individualism, of personal freedom, they're really at the center of the American way. And they confer a ton of innovation. It was so nice to hear Scandinavians saying, we love you guys because you're always coming up with new things and you can do it really fast. It was sort of heartfelt because we were slamming ourselves. And these values really need to be preserved. I mean, this is sort of who the country is. But unfortunately, when we do this, we really become blind to this undeniable fact that we share common resources. We are not only ourselves, we are connected. And we forget that health is in part socially determined. The good leadership, I think, really solves the collective problem. Leadership takes a look at what is the collective and how do we solve that, not the individual problem. But how do we mobilize to solve the collective problem? And we know that this is going to require trust, and we're low on trust. And we know it's going to require long-term time horizons. One of our interviewees said, oh, America has ADHD investor. You know, it's like, oh, you know, we'll go on to the latest fad. But to do this requires a longer-term view. And last, one has to be motivated to see the whole rather than cutting up the world into the many parts. And we need incentives to do this, and we need rewards for doing this. And I'm not sure we've quite figured out how to make that happen and what those incentive rewards and governance structures should look like to accomplish this. This is where we began. Our thesis is in the United States, we've really conflated these two. And perhaps the first step is starting to talk about these differently and really understanding that they just are absolutely not the same thing. So I thank you so much for your attention, and I'm delighted to talk about any of this more. Thanks.